Good morning. This is my fourth attempt at the Musculoskeletal System lecture component of Nursing 106, Module I, which includes musculoskeletal system, integumentary, and sensory systems. Today we're going to talk about talus equinovarus, hip dysplasia, scoliosis, fractures, muscular dystrophy, juvenile rheumatoid arthritis, osteogenesis imperfecta, Legg-Calvé-Perthes disease, slipped epiphysis, bone and muscle cancers, fractures and traction, and osteomyelitis. Starting out with talus equinovarus. Talus simply means club foot. It is a congenital condition. It's present at birth, and it's pretty obvious. We as nurses do pick it up most of the times. There are a lot of varieties of true club foot. All of them are not called talus equinovarus. The terms talus varus means that the toes or the foot bends inward, whereas talus valgus means the toes bend outward. Talus equinus is referring to the heel position, and like a horse, the heel is up and the child walks on their toes. Talus calcaneus is when the heel is lower than the toes, and when the child starts walking, they walk on their heels. Lots of varieties that it can be depending on the combination of toes in or out, heel up or down. The most common variety is the talus equinovarus. That's heel up, toes in. It can be unilateral or bilateral. As I said, it's present at birth, and so it's congenital, and it can involve the bone and soft tissue or just soft tissue. Things that are associated with talus equinovarus include position in utero. If they're in a position in utero where they cannot kick and move as much, their foot may tend to grow in this position. Also, congenital conditions such as a myelomeningocele, which leads to paralysis of the lower extremities. The foot is sitting in a position and the uterus will kind of mold it into whatever shape it's pointing into. And of course, it's always idiopathic. We don't have a cause from it. It just happens. And the majority of cases this is what we see. Positional clubfoot is when the foot only involves soft tissue, and it is noticeable at birth, but may not be real obvious. You have to look for it. And in this case, the foot can be rotated beyond midline. A true club foot, you cannot turn the foot beyond straight. But a positional club foot can go beyond midline. It may not be far beyond midline, but it can go beyond midline. It's very important that we pick these up and begin working with this child early on, teach the parents to do it, and it simply requires a passive exercise, kind of playing with the foot every time you change a diaper, rotating it and taking it beyond midline. When my children were young, I had a friend that had a baby about the same time as I did, and we were, as friends do, comparing babies back and forth. And the first time I saw the baby, it was probably 6 weeks old, and the one thing I noticed about the baby was that it had a club foot. And so, of course, without mother being aware of what I was doing, I checked it out. It was positional. It was actually bilateral positional. And so I kind of talked with her about who her pediatrician was, and I felt quite certain that this pediatrician would note this and teach her what to do about it. So I didn't want to be all nursey for a friend, and I didn't say anything. I felt very bad about 6 months later when she called in tears to tell me that her baby had been diagnosed with a club foot and they were casting the feet. Well, of course, this could have been prevented if I had spoken up at the time. But she was very upset, and as all mothers are, you need to understand this may be a minor disability that is easily fixed in most children, but it is a major disability when it's your child. And remember, every parent expects the Gerber baby, the perfectly pretty little baby, round face, hair, everything perfect. And this baby is not perfect. So it's very upsetting to them. And this mother was very upset with cast on the feet. Oh, it's going to delay him learn to walk. He's going to be behind the other children. And she talked about all her concerns about this. Well, children adapt very easily to that, and this little boy did adapt to his clubfoot very easily, his cast. As a matter of fact, he dented his high chair because he was kicking with his casted feet, and kicking hard enough it dented the high chair. He became very strong. His legs are his strongest part of his body, and he's a soccer player now, so I guess it didn't hurt his movement too much. But remember that if a positional clubfoot is not treated early on, and the earlier you start treatment with any of these, the quicker the resolution and the better the resolution. Okay, treatment, a couple of different types of treatment we might do. We might do serial casting, and that means that they put a cast on the foot or feet, and this cast is changed about every 2 weeks. It's changed for two reasons. One, the baby is growing rapidly, and we don't want it to become too small for the baby's foot. But second, each time they change the cast, they manipulate the foot a little bit more to the opposite extreme. So we're actually kind of training this foot to go into a more neutral position. Another option is a Dennis Brown splint. I'll show you a picture of that one in a minute. It may be worked by itself. It may be a combination of casting and then into the Dennis Brown splint. If these are not successful, if we don't pick it up early on, then the child may require orthopedic surgery to correct that. Nursing care of the baby with a casted foot or any kind of cast. Casts can be made of either plaster of Paris, which is very soft and very easily damaged, or it can be made of fiberglass, a much harder substance. When we are doing a cast on anybody, any extremity that's casted, you as a nurse should be doing neurovascular checks. You don't need a medical order to do this. You should not wait for a medical order to do this. This is nursing judgment, and that's what we expect of a professional registered nurse. Neurovascular check involves color, warmth, movement, blanching, and sensation. Now, you can't see the foot in this case. All you can see is the toes, but you're going to evaluate each of the toes for these 5 things. You can't say, well, the big toe is movable, therefore we're fine, because the little toe may be scrunched up in a position, cannot move, and you may not even be able to see it very well, but it may not be getting adequate circulation. So you've got to check all 5 toes. Notice there's no pulse asked for. Well, you can't find a pulse because they're not available. Okay, we need to think about whether this is a, timing of checks. Immediately after the casting, you do it frequently. As you get further away in time from the actual casting experience, then you can check it less often. So the typical routine is every 15 minutes times 4, every 30 minutes times 2, then every hour times 4, then go into once a shift and then once a day. If it's a plaster of Paris cast, you have to be careful about getting it wet. A wet plaster of Paris cast will disintegrate. It won't be supportive. It won't do any good. So you got to keep it dry. The baby cannot be tub bathed, cannot get this wet, cannot get it wet with urine either. So you need to protect that. If the cast gets dirty and it's just dirt, then you can put adhesive tape over it to hide the dirt. Notice the edging of this cast. This is a plaster of Paris cast, and the edging of it, this is that little felt lining, but the edging of it, the plaster of Paris, can get crumbly. If the lining is not protecting very well, then the crumbled plaster of Paris can fall into the cast and can cause damage to the skin and the tissues underneath. If that is the case, if you have a crumbly edge, you will pedal the cast. And by pedaling, we mean take adhesive tape and starting a strip of easy tape applied inside the cast, come up out over, so it's a strip that goes, would you say that's longitudinal? Then the next strip lays right beside it there. And so you wrap it all the way around the cast like a flower's petal, up and over the edge so it cannot crumble. A fiberglass cast can get wet, but I don't recommend it. We tell older children they can swim in it or they can even take a shower, but it takes about 24 hours for it to dry. It dries from the outside in, and it's very uncomfortable during that period of time. A fresh cast, whether it's fiberglass or plaster or Paris, must be allowed to dry. During drying period, you only handle it by your palms of your hand, never by your fingertips. A fingertip might indent the cast and create problems with vascular circulation. It also needs to be air exposed, so you don't want it wrapped up. You want to lay it out on the air. And of course, a fresh cast, we elevate the extremity to keep it from swelling. You want to be careful about objects being put underneath the cast. Sometimes older children will take a coat hanger and dig under the cast to scratch. This is not recommended because it can cause the padding to puddle up and create a vascular injury. Also, watch younger children for putting toys and other objects under the cast. You will see that happen sometimes, and that also creates skin breakdown and vascular issues. We had one mother that would take the child out and lay it on a blanket outside, and she got some bugs in there. So we want to watch and prevent anything from getting under the cast. More information on cast cares in your textbook, and you are expected to know it. Dennis Brown splint. As I said, some children may be casted for a while and then convert to the Dennis Brown splint. Others would be just in the Dennis Brown splint. I personally, as a nurse, prefer the casting. And the reason for that is when we first put the Dennis Brown splint on the child, these are shoes attached to a bar. It holds the legs in a certain position, which may not be the position of comfort for the baby. When the baby's in a position he doesn't like, he cries. If Mama has control over it and the baby's crying and crying and crying, what is she going to do? She's going to feel sorry for the baby. She's going to take the splint off, and she won't get the benefit of it. With a cast, she cannot get it off. Therefore, it will not be the problem. With this Dennis Brown splint, these are actually two shoes, and the toes are out of the shoes. It looks like they're on the wrong feet. I had one mother say, I am so tired of people telling me that my baby's shoes are on the wrong feet. I know which foot they go on. So recognize that they do look like they're on the wrong foot because we're trying to typically turn the foot outward. The bar holds them in that position, and over time we take the baby back into the doctor, and the doctor changes the position of the bar and the shoes. We want to be careful with this that we do not use the bar as a lift bar in changing the diaper, because that could weaken the screws and put it out of position. I want to go back for a minute and talk about cast removal. We're going to be doing a lot with cast in this section, and cast removal. Some of you may have had a cast put on and you had it taken off. And the taken off experience for a young child, I want you to think about what it was like. First of all, it's very noisy. It has a lot of dust coming loose because it's a saw. And they tell you, don't worry, it won't cut you. Despite the fact that they say that, it gets warm underneath and you think, yeah, they're wrong this time, they're cutting me. In order for any person, whether it's a child or adult, whenever you're preparing them for a procedure, you explain to them what's going to happen in terms of what they will see, what they will feel, what they will smell. In other words, their senses. It doesn't make any difference what you're going to do, but will they see, feel, smell, whatever. That's what you explain to them. So you would say to the child, we're going to bring this saw in, and it's really noisy, and it's going to get hot underneath, and you're going to feel like it's going to burn you, but it doesn't burn you and it doesn't cut you. It does have a funny smell, and it has lots of dust in the air, but it's not going to hurt at all. So you explain in terms of what they see, feel, smell, taste, whatever. Okay, we're not hooked up so that we can do this on your iPads or iTouches, but we're going to go ahead and look at the question and let you think about it. A child is born with talus equinovalgus. The foot position would be, equino means heel up, right, and valgus means toes out. So the right answer is 3, heel up, toes out. Okay, next condition is called hip dysplasia. The correct terminology in this day and age is developmental dysplasia of the hip, or DDH. Developmental dysplasia. Dysplasia means abnormal growth, development that occurs during the developmental period. So we're talking about around the time of birth. We typically tend to call it the congenital hip dislocation. When we think about the hip of a newborn, we now know that the hip of the newborn is not completely completed. It's not formed completely yet. The head of the femur does not sit securely in the acetabulum of the pelvis. This ball and socket are in loose proximity, but it's loose. The acetabulum is shallow, and the ligaments and muscles are weak. Hip dysplasia can involve one hip or both hips. But we really think that for the most part, hip dysplasia is something that is possible in almost any baby, because every baby has a shallow acetabulum, weak muscles and ligaments. It could happen to any baby based on their environmental and what happens to them during pregnancy and after birth. We can look at degrees. So what we're saying is that the difference between a normal hip and dysplastic hip is almost nothing. That the dysplastic hip is pretty much what we see as normal in the newborn. So we have a subluxation or subluxatable, which means dislocatable, and then we have the one that's already dislocated. Okay, subluxatable, the head of the femur can come out of the acetabulum. Dislocated, it is out of the acetabulum. So we have our levels of it. Really, we've studied different cultures and the frequency of dislocation in different cultures, and a lot of it seems to be positional. When we look at the American Indian practice of baby raising, what we notice is that the majority of them put their babies on papoose boards. Papoose boards actually are these hard wooden boards where the baby is strapped down and the legs, the hips, are extended and the legs are together or adducted. And we have found that the incidence of hip dysplasia is very high in the American Indian. On the other hand, in the Asian culture, the women tend to wear their babies, and they put their babies kind of on their hip in a sling type device that causes the hips to be flexed and abducted, and they have a very low rate of dislocation. So our theory now is if we can keep that hip flexed and abducted while it completes the growth process or the developmental process, the hips will develop normally. Things that contribute to hip dislocation, just like we just talked about, things that can contribute to is genetic factors. Genetic factors could be muscle weakness. A child with Down syndrome tends to be a floppier baby. Therefore, the joints and the ligaments are looser and easier to dislocate. Breech presentation. You can look at this baby, you notice mother's not holding it at all, but it's laying in this strange little position that's called its position of comfort. This was the position it was in utero. You recognize this as frank breech because Frank is saluting with both feet. But his hips are extended and actually pulling the hips out of the socket, the head of the femur out of the socket. Position after delivery. The current thing that we think contributes to that is using the legs, the feet, as levers to lift the buttocks up to change the diaper. We never pick the baby's buttocks up by the feet. Slide your hand under the buttocks and lift it up that way. And then physiologic factors, again related to position in utero and the lack of the ability to exercise. Multiple fetuses, it's too crowded in there to exercise, to flex and extend those hips. Oligohydramnios, insufficient amniotic fluid, makes it more crowded in there. And a large infant, all of it's the same thing. The crowding prevents the exercising of these hips. Hip dysplasia can be observable. You can pick it up. You should be looking for it in the newborn nursery. The physician will check for it by doing a test that's called an ortolani. He will place the baby flat in his crib. He will flex the hips and the knees, putting the feet right on the bed by the buttocks. He will then place each hand over the hips, over the knees. His thumb is on the inside of the knees. His third finger is over the hip joint. He will then abduct, pull outward, turn it outward. If this is a dislocatable one, or if it's dislocated, he will feel it jump out of the socket, and you may even hear a click as it does that. In an older child testing for hip dysplasia, they will do the Trendelenburg test. Because the connection of the head of the femur and the acetabulum is important to the stability of the bony structure, the child who has a dislocated hip will not be able to maintain this stability. So they will ask the child to stand on one foot. When the child stands on the good foot, the pelvis remains level. When the child stands on the affected side, because the head of the femur is not in the acetabulum, there's no stability, and you will actually see the pelvis shift. Symptoms you may notice, because we don't typically do the ortolani, and of course these babies are too young to do the Trendelenburg on. Symptoms that you may notice. If it's a unilateral, it only affects one side. Place the baby flat in the bed, put the feet, flex the hips and the knees, and place the feet right by the buttocks, and you may notice that one knee is higher than the other. Or when you turn the baby over and they lay on their belly, when you look at their little rings on their thighs, they will have an unequal number. In a bilateral, especially in a little girl, you will find a wide perineum because the femurs are up and behind the normal site, and so it makes the perineum look wider. Untreated hip dysplasia will lead to a shorter leg on that side, hip instability, a delayed walking. Because of this lack of stability, they will be slower to learn to walk. They will learn to walk, but it will be slower. They will have a characteristic limp, almost a waddle, and they will tend to walk on their toes. Treatment. We want to keep the hips flexed and abducted. Several ways we can do that. We used to do it with a double diapering. We'd actually put 2 or 3 thicknesses of diaper on this baby, and that created such a thickness that it flexed and abducted the hips. The problem with that is every time the parents changed the diaper, if they picked them up by the legs again, we had now just taken away anything we've just done. Other options available, one's called the Pavlik harness. And the Pavlik harness is canvas straps, and it just really goes over the shoulders and attaches to the feet and legs. And the purpose is to flex and abduct the hips. Obviously, you can change the diaper in this baby without a problem. Clothing, somewhat restricted what clothing they wear. Onesies work fine, but most of your longer outfits won't work at all unless you take it off and put it on there, and that means each time you change the diaper you have to change, you have to remove the harness. That's not good. They wear the harness 23 hours a day. And then there's the Von Rosten split, which is like having 2 padded rubberized coat hangers go over the front of the shoulder, down the back, and then under the thighs. So again, it's flexing and abducting the hips. This works well because moms can't get it off. Therefore, if the baby's fussy about it, they won't take it off. Diaper change is easy. Many of the clothing will fit over it, so this works well. That's the Von Rossen split. Again, 23 hours a day. We do put a t-shirt under the straps to prevent wearing. We want to watch them for redness. Avoid lotions and powders under these devices because they will create friction, soften the skin, which we don't need, and cause breakdown. And they wear it 23 to 24 hours a day. If we don't pick it up early, if our treatment is unsuccessful, the child may require traction, as you see here, then surgical correction, and finally placement in a spica cast. A much longer, more difficult, with more complications. So definitely start treatment early and follow through, and they usually do really well. Okay, you observe the following in the newborn. You would suspect bilateral or unilateral hip dysplasia. Well, the baby's not laying on their back, so we can't check knee height. Really can't get a good grip on the perineum there because of the way it's laying. So let's look at thigh. Look at the thighs. Do you see the difference in the rings on the thighs? Hence, that means we have a unilateral dislocated hip. Okay, the spica cast, here we see the spica cast in use, and it typically, anytime a spica cast must cover the joint, and typically the joint below. So you will see it going up the chest and then at least down to the legs, but usually maybe a little bit further. Notice the perineum's cut out. We are going to have to cover that with plastic wrap to keep it dry and clean. We're going to pedal the cast. You can see the pedaling at the top of the cast. And again, if you have the one with the bar is not used to lift the legs to change the diapers. This child can be active, can be carried any place. Car seats can be a problem. They don't really fit in car seats. But other than that, a lot of things, because they're young, a lot of things can happen with them. Okay, scoliosis. Scoliosis is a spinal deformity where there's lateral curvature of the spine. Anytime you have a curve in one area, you have to have a curve in another area so that you remain in a straight upline position. So what you notice is that there's actually two curves. It can be congenital. There's such a thing as a hemovertebrae. And a hemovertebrae means hypervertebrae, but what really it is instead of a rectangular vertebrae in the back, it is more of a triangular one. So you have the spinal cord coming up from the bottom, hits that triangular, right angle triangle vertebrae, and that throws the rest of the vertebrae off at a different angle. So it can be present at birth. Most commonly, scoliosis, though, is secondary to other conditions or idiopathic. Neuromuscular conditions. We see scoliosis a lot in children who sit in wheelchairs 24 hours a day or all their waking hours. They tend to sit in the same position. They often lean one direction, and they will develop scoliosis. If they have a weakness in the muscles, such as muscular dystrophy, we'll talk about that. That could lead to scoliosis. But the majority of cases are idiopathic, maybe as a result of rapid growth in adolescence. More often than not, it occurs more often in girls. But let's think about what girls do that guys don't do. We carry purses. We carry purses on the same side all the time, typically. And we have everything we own in that purse. So again, by habit, we start doing that, leaning in that direction, and that can lead to the curvature. Most times schools are mandated to do scoliosis screening. We usually start around 4th grade when we start seeing the growth spurts and we start seeing more of an issue with it. Some of the things that may be noticed, mother may notice it because, especially if she sews or she's buying clothes for the child, they never seem to fit well. Notice how on this girl that we're looking at, the t-shirt she's wearing wants to lean in one direction. Well, if that was an outfit, it would be bunching on one side. Mother may say, well, my pants leg, one pants leg always seems to be longer than the other. Or I'm hemming the skirt and I can never get them even. Diagnostic, we're going to, in our screening evaluations, we're going to have the child in minimal clothing, underpants only. And we're going to stand there looking at them from the back. You may actually see the vertebrae curvature, or you may notice that the height difference in the shoulders. You may also notice that the shape, the prominence of the scapula and the iliac crest is different from one side to the other. We will then have the child bend forward at the waist as if to touch the toes, and you will see that one side is higher than the others. They have a little device that they run right down the vertebrae, and it measures the degree of scoliosis, and that way we can report it and monitor to see if it's increasing. X-rays, of course, will show the deviations. And so we're going to start treatment. Most times, if it's not a hemovertebrae, treatment will be aimed at bracing, stabilizing, and exercise. Bracing to stabilize it, and they will wear these braces 23 hours a day. The other thing they will do is that when they take the brace off to shower, they will have them do a series of exercises designed to strengthen the muscles supporting the vertebrae. If this is not successful, or the degree of curvature is too large or is increasing, they may choose to do a spinal fusion and rod insertion. And this is what you see. This is a surgical procedure where they go in and they will put this metal rod, screw it into the vertebrae to hold it straight. Many times prior to this, they may use the casting and bracing type thing, or they may put the child into traction beforehand. This can be such a shock to the system that if they just do it suddenly, it will cause all kinds of muscle spasms. So they will put the child in head pelvis traction, pulling apart, so we're stretching the muscles, the ligaments, to make it easier. And also, when you think about scoliosis, we have one side that's being compressed, one lung that's being compressed, and we have one lung that's expanded. When we suddenly correct it, the compressed lung is now expected to do double duty, whereas the lung that's been doing most of the work prior to surgery is now not as available. So that traction will help that. Nursing care, we need to teach the child how to care for the braces or cast. Recognize that these braces and casts are designed to prevent bending of the vertebrae, so the child typically cannot sit in a regular chair. They can lean, they can stand up, and they can lay down, but they really cannot bend to sit. Think about self-esteem and body image. We're talking about adolescent, pre-adolescent girls especially, and they want to look like everybody else, and there is no way you can hide these braces, these casts. So we need to talk to them about clothing that they can wear to hide it as much as possible. Have them meet other children who've been through it. That can be helpful. If they have to have the rod insertion, the Harrington rod insertion, post-op care becomes very important. The area is very fragile. The screws have damaged the bone and would lead to breaking very easily, and this would traumatize the spinal cord and could lead to permanent paralysis. So we log roll the child when we move them, and that means we turn them as a unit. The whole back turns as a unit. They are flat in bed, no pillow, and they cannot sit up, flat in bed, cannot elevate the head of the bed. When pain management, they have muscle spasms and they've had surgery, so they're uncomfortable with that. Wound care is a big issue. We don't want to become infected. Range of motions. If we do not use our muscles and our bones, if we put no pressure on the bones, the body removes the calcium from the bones. It circulates, it goes into the kidneys to be excreted, and can lead to kidney stones. So we want to maintain the strength of the bones and the muscles, and we do range of motion of all the joints several times a day. Bladder and bowel, it's often very hard to void. You're flat, they'll be placed on a fracture pan. They may be afraid that they're going to wet the bed. You have to assure them that's not a big deal. We can change the bed, log rolling again. Bowel movements, they're not active. We need to watch them, make sure they don't become constipated. They may need stool softeners or even laxatives. Again, with the bladder, we have to watch for urinary tract infections and particularly watch for kidney stones. Recognize that little boys normally stand up to void, and in this case they're flat in bed. School is an issue because they may be in this position for 6 weeks and then they're going to go into a cast, and so they may not be able to return to school full time. They may be have to be out for an extended period of time and then do half-time school. Here's another question. In the immediate post-op spinal fusion period, the priority nursing concern would be. Now, notice that I didn't mention respiratory function, but when we think about Maslow's hierarchy, number one concern is airway. And this child, remember we talked about the compression of the one lung that's now becoming the primary lung of function. And so if we don't do it, they're also flat in bed, they're not moving much, they're very susceptible to respiratory infections, pneumonias. So our number one concern is respiratory function. Cough, deep breathe, pulmonary toilet, and turning them. Once the surgery is over, again, they will go into cast, and then we'll be going home, and may need to be homeschooled for a period of time, then go back for half a day. Again, with the situation that they are leaning, not sitting in school. Muscular dystrophy. We tend to think of muscular dystrophy as being one disorder, but it's actually a group of disorders that involve progressive muscle degeneration. Interesting thing about muscular dystrophy is that no matter which type of muscular dystrophy you have, it involves symmetrical muscle groups. So if the muscles of one part of the body on the left side is affected, the same muscles on the right side of the body will be affected. It does have a genetic component. Many of these we know how it's inherited. There is a metabolic disturbance as our theory, but we do not fully understand what happens that causes the degeneration of the muscles. I'm going to talk about the types. Notice the picture of the side that shows you which muscle groups are going to be involved. The limb girdle. It's autosomal recessive, means both parents have to be carriers in order for the child to be affected. The onset is late childhood, so unless they know they're carriers for it, we don't have any clue until late childhood. They develop weakness of the pelvis and the shoulder girdles, but it's very slow progression, and 20 years from late childhood, so maybe when they're 40, 50, they will become disabled, need a wheelchair. Then we have facial, scapulohumeral. Okay, notice the muscle groups that's involved here. It's inherited as autosomal dominant, meaning only one parent carries the negative gene. Onset's early adolescence, involves the face and the shoulders, progresses slowly, have a normal lifespan. Then Duchenne, and this is really the only one I expect. There are others, okay, but this is the only one I expect you to understand fully. Other than knowing that there's muscular dystrophy is a group of disorders, I want you to know Duchenne is the most common. It is pseudohypertrophy. It's a false enlargement. In Duchenne's muscular dystrophy, the muscles are replaced by fat. Fat is bigger than muscles, so the child looks very large, very muscular, but in fact, they're not. Inherited sex-linked recessive, carried by the mother, affects the male. Onset's early childhood. Let's see if this will work here. I'm sure that it will, but we'll give it a try. Notice that the child's positioning as they age, and that's to maintain their center of gravity.
You know me. You've seen me at the mall, the movie theater, or the grocery store. If you're young, you stare at my power wheelchair because you think it's cool. If you're a teenager, most of you try not to look at me. And if you're an adult, a lot of you are pulling your kids away from me. What you don't realize is that I'm just like you. I like to do most of the same things that you do, but I am limited because I was born with a disease that quite a few of you have heard of if you've ever watched the Jerry Lewis NBA Labor Day telethon. My name is Brian Arnold, and I am the face of muscular dystrophy, Duchenne's muscular dystrophy to be exact, and I want to tell you my story. Living with muscular dystrophy can be quite a challenge. My parents didn't know I had it when I was first born. When I was around 4, I started tripping and falling, normal things that happen to kids that age. By the time I was 5 and at school, it was hard for me to get up from the floor anymore, and I fell all the time. The nurse at my school knew something was wrong, and so started the journey I was destined to take. Duchenne's muscular dystrophy slowly takes away the use of your muscles. The first to go are usually your leg muscles. At 6, I couldn't climb stairs anymore, so my parents had a ramp built so I could get in the house. I had to start using a wheelchair when I was 9. I remember my teacher making sure my best friend was with me when they brought it to my school. Since I got a power wheelchair, I could still be pretty normal. It was actually quite a lot easier than walking. I could go just as fast as the other kids at recess, and was involved in all of their games. I liked being able to go fast, and as a result, flipped my wheelchair quite a few times. 7th grade saw a change to another school, and I also needed a full-time aide to help me with scribing and other daily tasks. Accessibility was a challenge at my new school, as they had never had anyone in a wheelchair there before. But they made some changes, and I'm still here today. It's been hard here because I didn't know anyone here but my brother when I first came. I found one good friend who has stuck by me for 5 years. If I had one wish, I would wish that all kids could see me for who I am and not just see the wheelchair I'm in. It's just like elementary school when you're the last kid picked in a kickball game. Kids today have the power to change that. I'm just like you, except muscular dystrophy is making all my muscles fail. I can contribute a lot to a group, and I like to do the same things as you do in my spare time. See me for who I am. I know it's possible. This year, I started taking an advertising art and design class at King Career Center. The kids in my class here include me in everything. It's a great feeling to know that they accept me as the person I am and don't see the wheelchair at all. It's said that we are a generation that likes to do things our own way. And I think changing attitudes about kids like me would be a great place to start. There are organizations out there that help me feel like I am a normal kid. I've actually been skiing at Alaska. Challenge Alaska has 2 skis for people in wheelchairs to use. I probably could have beaten quite a few of you down the mountain. I know it was one of the coolest things I have ever done. I play wheelchair soccer with Play Sports every week. Kids that don't have a disability can play with us. The only requirement is that you have to use a wheelchair. Sometimes the kids without disabilities have more fun than the rest of us. The Muscular Dystrophy Association also has a camp every year that you can go to. It's a week full of fun things to do like swimming, boating, and games. My favorite day is when all the Harley-Davidson people come on their motorcycles and give us rides in their sidecars. There's also a group of people that bring old cars and limos for us to ride in. Camp is something that most kids get to do, and it's fun that we can as well. Life in general for me has been full of doctor's visits and constant changes. The Muscular Dystrophy Association holds clinics all year long, so people with muscular dystrophy can see a lot of doctors all at once. There is no cure yet. The doctors try to make life easier. I had heel cord surgery on both legs when I was in 6th grade, so my feet wouldn't bend down all the time. Other doctors monitor our respiratory function. Show parents with kids like me physical therapy exercises that will help us and keep up with the changes that have occurred each year. The past year saw a lot of changes for me. I recently had a feeding tube put in because I had lost so much weight, had 2 kidney surgeries to get rid of kidney stones, and also had a tracheostomy so I could go on a ventilator to help with my breathing. This also meant that I now need a full-time nurse at school as well. I'll probably have scoliosis surgery in the near future to help straighten the curve in my back and make it so I can stay comfortable in my wheelchair for longer periods of time. I spent 18 days in the hospital, so it's been quite a long winter for me. But almost all of us with Duchenne muscular dystrophy eventually end up on a ventilator, so I knew it was coming. The surgeries help to extend our lives, so it's worth it in the long run. The longer we live, the more hope there is that a cure will be found for this disease. I am thankful that the Muscular Dystrophy Association never gives up. I have big plans for my future, plans that include college and a career in advertising. So don't count me out just yet. Accept me for who I am, because someday I might be working right alongside you.
Okay, so you get an idea of what it's like to be a child with muscular dystrophy. One of the classic symptoms of muscular dystrophy is Gower sign, and Gower sign refers to the way that the child arises from the floor. Because of the lack of strength in the lower extremities and the whole vertebrae, they actually climb up their body. They use their body to push themselves up, and that's called Gower sign. By age 12, they're usually not ambulatory. Now we do not ever rush them. Do not think about, oh, we'll get them a wheelchair early, that way it'll save their energy. The faster they go into the wheelchair, the more they deteriorate. So we would try to support them in other ways without pushing them to the wheelchair, because once you go that way, it's just downhill from there. There is a mild mental impairment associated with it. It does progress rapidly. Most of these children die in early adulthood. From obesity, respiratory and circulatory conditions are the big issues. Medical care is supportive. Diagnosis is made on, they can do a genetic detection of the dystrophin, which is a muscle protein, by DNA analysis of the blood. They can do a muscle biopsy where they expect to find in Duchenne's the muscle cells have been replaced with fat cells. Serum creatine kinase, CK levels are high in the first 2 years of life. Okay, juvenile rheumatoid arthritis. Now it's really juvenile idiopathic arthritis. Change the name because the majority of these are not rheumatoid, but they are idiopathic. We don't have a cause for them. When you think of JIA, you would want to think of Webster on TV. He was a JIA child. But this is not just one disorder. Again, this is a group of disorders that involve chronic inflammation of joints and other tissues. It most frequently affects girls, 2 to 1, and the age of onset is either 1 to 3 or 8 to 10. That's when we see the peaks. Those 2 age groups have the peaks of onset. There's inflammation of the joints, and there are fluid collecting in the joints that will eventually destroy the joint, and you will have loss of function of the joint. Adhesions occur, again, loss of function, alkalosis. Symptoms, it can be a single joint involvement or it can be multiple joint involvements depending on which type it is. The joints are swollen, they may be warm to the touch, usually not red. Sometimes they are, but usually not. Limited motion, it hurts, okay? And if they don't keep them moving, it will develop ankylosis, which is a loss of function. Like the old lady, they are stiff in the morning, get better as they move around. Movement is very, very good for them. The other big issue is growth failure. Think about Webster and how small he was. He was much older than he appeared because of his growth failure. Prognosis, it is not a fatal disease. It is unpredictable. It tends to wax and wane. That means it gets better and then it gets worse. It becomes inactive in most of the cases. Diagnosis, they look at ESR, remember that's erythrocyte sedimentation rate, and that simply means inflammation. Leukocytosis, an elevation of white blood cell count, again, inflammation. And anti-nuclear antibodies may be present. Treatment, no cure. Our aim is pain control, preservation of joint function, and normal growth. Medications they may be using, NSAIDs, which you're familiar with, non-steroidal anti-inflammatory drugs. If you don't know them, look them up. We're also seeing them use SARDs, which is slower-acting anti-rheumatic drugs, which include methotrexate. Methotrexate is typically a cancer drug, and sometimes when parents are told, we're going to put your child on methotrexate, it's, does he have cancer too? No, it's used for the reducing the inflammation, the response of the body, and it's different dosing. Corticosteroids, anti-inflammatories aimed at reducing inflammation again. NSAIDs. NSAIDs can be COX inhibitors. COX, and that's what COX stands for, is an enzyme that synthesizes prostaglandins. Prostaglandins, remember, is your chemical pain message. So this enzyme causes the production of prostaglandins. If we inhibit COX, we are therefore going to inhibit the production of prostaglandin, so you don't have a chemical message there. COX also protects gastric mucosa. It helps blood to clot, the platelets to clot, and promotes renal blood flow. Hence the side effects of NSAIDs. COX inhibitors, NSAIDs, do not prevent joint damage, do not slow the disease progression. All they do is reduce pain. There are now first and second generations. First generation is aspirin, ibuprofen, naproxen. We now have second generations, which are good for reducing pain transmission, but doesn't affect the stomach and kidneys as much, doesn't affect the clotting, and that's Celebrex and Vioxx. Recognize that Celebrex, Vioxx have been shown to have heart problems. I'm not sure if Vioxx is still on the market. Definitely Celebrex is, but it's very controlled now. Notice here I say that acetaminophen is a COX-2 inhibitor, but the problem is it's not an anti-inflammatory. We now have another drug called DMARS, which is a disease-modifying anti-rheumatic drug. And the thing that they're doing now is they're starting these drugs earlier versus waiting until there's damage done. Glucocorticoids used for short-term, you know that if we use glucocorticoids, corticosteroids all the time, this would suppress your adrenal gland. You need your adrenal gland to function. This is what gives you your fight or flight reaction. Treatment, occupational therapy. We want to keep them moving and make it as easy as possible. So you want to think about what kind of movement will keep the joint functional but will not damage the joint. Think about the difference between running and exercising in the pool. Running is pounding on the knee joints. Exercising in the pool, there's no weight there, so it's not going to damage the joints while maintaining range of motion. Okay, here's a question. Which of the following activities would provide the best range of motion for the child's hip joint? You may see on the test you're trying to provide passive range of motion for X joint. Which would be the best activity? When you get to that point, I would expect to see you mimicking that activity so you can determine which is going to give you full range of motion. So here our choices are running, riding a tricycle, riding a big wheel, riding a horse. Without knowing anything else, one is running and the rest are riding. So I'm betting it's going to be one of the riding. We've already mentioned that running is hard on the joints. It's the weight bearing and it's much more damaging. Some of you may not know what a big wheel looks like, but that's a big wheel right there. And how does that differ from a tricycle? Okay, because the right answer here is riding a big wheel. Now we're looking at the hip joint. When you ride a tricycle, I want you to picture yourself riding a tricycle. Your knees move and your hips a little bit, but not much. When you're riding a big wheel, you're leaning back just a little bit, and the main action is flexion, extension of the hip. So riding a big wheel is the best answer. Osteogenesis imperfecta, a very unusual disease, usually inherited as autosomal dominant. There are multiple types that you don't have to worry about the types. Osteogenesis, the formation of bone, is imperfect. Children with osteogenesis imperfecta, depending on which type they have, will have bone fragility, and the degree of fragility depends on the severity. Here we see this little baby down here, and you can see that this leg is way out of position, and what has happened is it has broken and healed itself in this strange position. This happened in utero. So it was simply the fetus's movement in utero against the uterine wall that caused the break. How fragile that bone is. The blue sclera, when you look at the whites of their eyes, it's not white, it's blue. They have problems with their teeth. They're hypoplastic. Again, that same gene is controlling the teeth formation. They won't be very big. They don't grow well. Often confused with child abuse. If you don't know that this child has something goes on and they come in and we x-ray them and we find that they have several fractures at different stages of healing, that might make you think that somebody's abusing the child. There have certainly been cases where a parent was jailed after the child was brought to the hospital because of suspected child abuse. I had one little girl that we cared for a long time that had a very severe form. My first introduction to her was she was about 2 years old, and they brought her up in a little baby buggy, and I looked down in the baby buggy, and this little bitty baby with lots of hair, that was the unusual thing. It had long hair down to her shoulders and it's black. But she looks at me and she says, "Hi." Now, she was about the size of a 6-month-old. 6-month-olds don't usually say hi to me. It's kind of like, what's going on here? Well, that was the growth failure. This little girl had a very severe form. If you just picked up her arm with your hand, you probably would break it. We had to handle her, again, with the palms of our hand. We tended to carry her around on a pillow or something like that so that we were not moving things against her. We had to do a spinal tap on her one time, and it was my duty to hold her in that position, you know, the arched back position that we use for spinal taps. She didn't want to be in that position. She was fighting me all the way. She was tiny, so I was holding her buttocks and her arm down with one hand, and she didn't want to be there, so she flailed the arm back, and I felt it break under my finger. That was how easily she fractured stuff. And of course, you cannot cast them because the weight of the cast would break something else. So we try to position them in a normal position and help them heal, but they will have multiple fractures. Legg-Calvé-Perthes disease. It's also called aseptic necrosis of the capital femoral head. Aseptic, no organisms growing. Necrosis, dying of the tissues of the capital femoral head, and that's the head of the femur. You see it on this x-ray. Here we have a normal hip with the head of the femur. Look over here. There, the bone is gone. It's necrosed. It's died, and that's what's caused. We don't really understand it fully, but we know that something happens to the circulation to the head of the femur. It dies off. When that happens, the bone dies. When you continue to walk on that, it will flatten the head of the femur. And that's truly the case of what's going on. This says 4 stages. I think of 3. Don't get upset whether you want a 3 or 4. Each stage lasting about a year. So there's that period of a year where the blood supply is dying off and the bone is dying off. Then you have the stage where the bone is returning, and finally you have the formation of a new head of the femur. So about 3 years. Symptoms are hip and referred knee pain. One of the problems is that the pain from hip is also often referred to the knee. So the parents bring the child in for knee pain. If the doctor's not aware of Legg-Calvé-Perthes disease, maybe he x-rays the knee, there's nothing wrong with the knee, oh, it's growing pains. Obviously it's not, and so we have to be very careful with it. The other thing is the child may have a limp. Treatment is non-weight bearing. If they continue to walk in a normal fashion while this bone is reforming, it flattens the head of the femur, so now we have a flat not a circle, but a flat head of the femur and a round ball for it to fit in. A square peg and a round hole. They don't work together. This will destroy the head of the femur, and eventually they're going to have a hip replacement. Okay? But if we prevent them from bearing weight on that hip, then we can prevent them from flattening that. It will return to normal. So you may see on a smaller child they will do this non-weight bearing, the abduction brace. Notice the child is kind of in a position where they are always walking kind of with their knees flexed, and that's keeping the hip flexed and keeps the weight off the head of the femur. Another option is it can be non-weight bearing, and they might use something like this leather harness to keep the foot off the floor. We don't want them walking on it at all, and they would need a walker then to go with it. Again, if we don't treat them, or if we're not successful with our treatment, then they may need a hip replacement as a young adult. Why would a hip replacement be necessary years after treatment failure for leg cavity-perthes disease? And of course, we just talked about that. And yes, ischemia is a part of it, but remember, ischemia, the blood comes back without us doing anything. It's a flattening of the head of the femur. When you think about leg cavity-perthes disease, you've also got to think about slipped femoral capillary epiphysis, which is has similar symptoms, can be confused with it. Slipped femoral capital, so the head of the femur, the epiphysis, and this is the neck of the femur. And what happens is it slips. When you slip, something kind of doesn't break apart, but it separates somewhat. Seen most frequently in rapidly growing or obese children, so pretty much covers the whole thing. And again, both of these are those conditions that occur in that age, usually of 10 and 12-year-olds when we see it most often. They're idiopathic. We don't know for a cause of it. But the head of the femur just slips. If we don't pick it up and treat it, it could continue to slip and eventually separate. And so you need a new femur. Treatment is hip pinning. You see the pin where it's put in, and that's just done to stabilize the head of the femur. With both of these conditions, leg cavity-perthes and slipped epiphysis, both of them tend to occur on one side. But, I've seen several children that come back in maybe a year later, 2 years later after we've treated the first, and the other side's doing the same thing now. You don't see it bilaterally initially, though. Bone cancers. We have osteosarcoma, and the difference in the two bone cancers we're going to talk about is where they come from. This is arising from the mesenchyme of the bone, the middle, the metapiphysis, the shaft of the bone, the mid part of the bone. It tends to be the long bones, although it can occur in other bones, predominantly in adolescent boys, and it's the sixth leading cause of cancer of children under 15. It's associated with previous radiation exposure, so if they've had a lot of, not just an x-ray, but if they've had a lot of radiation of an area, then this is more likely. And again, we know that radiation is associated with changes in the structure of the cells, and that can lead to cancer. Also, they have found that many of these children will have an abnormal gene listed as P53, and they think that this gene is a tumor suppressor gene. Symptoms are pain, swelling, limp, the pathologic fractures. Pathologic fractures, because this is a bone that's become cancerous, it weakens the bone, therefore walking may suddenly cause the bone to fracture, doing nothing out of the ordinary. And so the fracture occurs not because of an injury, but because there's pathology in the bone itself. Diagnosis is x-ray. This x-ray here, you can see that the bone changes, that the bone is deteriorating there. The cells are no longer hard bone, but now they are cancer cells. CT, MRI, bone scans, serum alkaline phosphatase and lactate dehydrogenase are elevated, and these may be clues that they have that. It does metastasize to the lungs, the kidneys, the adrenals, the brain, and pericardium, so it's very important that we treat this early. They may choose to do limb salvage, or they may amputate. Here you see an example of limb salvage where they've gone in and removed the cancerous part of the bone and replaced it with a rod there that's stable to connect the two pieces of the shaft. Amputation might be a possibility. Child will be treated with chemotherapy. I want to remind you of Ted Kennedy Jr. was diagnosed with osteosarcoma at the age of 12 and had an amputation shortly thereafter. It has not stopped his activity. Here it shows him skiing with others, with family members. Another cancer is Ewing sarcoma. It arises in the bone marrow, along the shaft, along bones in the trunk. Occurs primarily in whites and Hispanics. And in this case, there's a translocation of genes, and that just means gene 11 is in 22 place and 22 is in 11's place. Treatment is less likely to involve amputation. Survival rate is 60%. Not as likely to survive this one as you are to survive osteosarcoma. We do chemotherapy, and it is also very radiosensitive, so they may treat it that way. Symptoms are swelling, pain, fever, elevated white blood cells, erythrocyte sedimentation rate, SED rate, and C-reactive protein, all indicating inflammation. They may amputate. Again, they may not, depending on the severity of it. Limb salvage surgery is the most common, and chemotherapy. Think about body image disturbances, especially for those who have amputations, how they're different. Post-op care of the amputee, surgical site that you have, chemotherapy, treating chemotherapy, mobility issues that's involved. If an amputation is involved, we want to fit them for a prosthetic as soon as possible. Some of you may know that I have a son with a below the elbow amputation, and it was over a year before he's got his prosthetic for different reasons. And for that reason, he became very accustomed to doing things with one hand only. And he can do just about anything you can do except tie his shoes. He cannot tie his shoes. So when he finally got a prosthetic device, and it was paid for by the insurance company because it was a work injury, he has this very elaborate prosthetic device that you cannot tell from a real hand. It opens and shuts. It's really amazing. Several years ago, my younger son was getting married. He was going to be I started to say pallbearer. I don't mean that at all. He was going to be an usher there, and so I told him, I want you to wear your hand. Wear your hand. Well, they had trouble because they couldn't find it. They finally found it. It was in the toy box because they never use it. The kids have been playing with it. But he's very concerned about this prosthetic device. First of all, he's not used to it, but second of all, it is his right hand. He's afraid people will want to shake hands with him, and he will inadvertently crush their hands. That's how strong this thing is. Obviously, you've got to prepare the stump, and that involves shaping the stump and getting it into the right mode. For the prosthetic device, they often will put a temporary prosthetic device on before they go with the real one. And phantom limb, that's L-I-M-B pain, is a common reality. This comes from the surgery. The nerves have been disturbed. Many times the nerves that might have been in the lower part of that extremity have been moved, and they're maybe turned around, and so they really do not feel the lower extremity. They just feel like they do. You hear old wives' tales about somebody said that when his arm was amputated, they must have buried it with the hand clenched, and so they could go and dig up the stump, and sure enough, the hand was clenched. They unfolded it. That solved the problem. That's not going to solve the problem. It's the nerves that's left that they're feeling pain. My son actually had surgery to help him with the flexion of the elbow, and after the surgery, he had a major problem with the making it flex. Even though it was flexible, he had trouble making it flex because the movement to flex the elbow was different. He had to shrug his shoulders in order for the elbow to flex because of the movement of the nerves, or what he felt was where the nerves were. Osteomyelitis, infection of the bone, things that can cause it. Open fractures definitely will cause it. Open fractures being fractures coming through the skin. Bone trauma, and most osteomyelitis is acquired through the bloodstream. It's usually bacterial, can be Staph aureus. Pain, swelling, decreased function are symptoms. Diagnosis, elevated white blood cell count, Cedrate, C-reactive protein, that just tells us there's inflammation in the body. A blood culture will identify the organism. Whatever the organism that's in the bone will also be in the blood. X-rays. They may do a needle biopsy. That's not as common because now we have a draining wound. It means they have to be on isolation. They will need intravenous antibiotics. Because the blood supply to the bone is not as adequate as other tissues, it is going to take a higher dose of antibiotics and longer term of intravenous antibiotics. So they're not going to go home in a day or two on PO antibiotics. It's not going to happen. Could be resistant staph, and they are at risk for pathologic fractures. Okay, we just talked about this, and of course you know that the answer is blood culture. Fractures. Looking at the types of fractures quickly. Complete fractures, complete break in the bone. You can see this. When bones break completely, the muscle, if it's a large muscle mass around it, such as the femur, I think that's a femur, could be the humerus, might be the humerus, I think it might be. But anyway, the muscle mass around it, the large muscle mass, will cause a spasm of the muscles, which will cause an overriding of the bones. And you can see how these two bones are not meeting up. If it heals that way, it would heal with a shorter arm or leg, whichever it may be. Comminuted fracture, this is definitely a femur, and you notice not only do you have the complete separation, but you have little pieces broken off. That's comminuted. Compound fracture, the bone is coming through the skin, therefore a good source of infection. Green stick is what we see in very young children. Just like a green stick or a green twig, when you try to break it, it tends to bend on one side and break on the other. So it's not a complete separation. Pain, abnormal position, inability to move, swelling, redness, and bruising. Actually, on this arm, you can see this placement of the bones. First aid, immobilize it. And remember that when you immobilize a fracture, you've got to immobilize the joint above and below. I want you to hold on to your wrist bones, and then I want you to move your arm. You feel those wrist bones move. So if we broke our arm, our lower arm, we would have to immobilize that wrist joint as well as the elbow joint. Diagnosis is X-ray. Treatment is cast, traction, sometimes surgical alignment, and maybe pinning. We're going to talk a little bit about traction here. When you're thinking about traction, you got to differentiate traction from counter-traction. Traction is simply the pull. If we have traction with no counter-traction, you just keep on moving down the hallway. You're just being pulled on. But our body weight is counter-traction. In many cases, the amount of traction required to overcome that muscle spasm is so high that we don't have enough counter-traction. So what they can do is add to our counter-traction, such as in this case, we're elevating, this is a fractured humerus, okay, arm, and they're elevating that side of the bed so that gravity is again pulling on the shoulder to keep that in line. Increases the counter-traction. So that's traction versus counter-traction. Also, you need to think about skin versus skeletal traction. Skin traction involves fast tracks, and that's what these things are called, that wrap around the foot and go all the way up the leg. And you notice that the traction is attached to that fast track. They actually are glued to the legs, and then we use a bandage around it to keep it intact. As a nurse, fractures, you do not release a fracture from traction ever. If the child is going to go up to have a cast put on, the orthopedic assistant will take them out of traction. They will go in their bed, and it will be done under very careful precaution. You never remove traction from a fracture. Okay, this child over here has skeletal traction. In this case, there is a bone, a pin placed through the skin, through the bone, and the traction is applied directly to that pin. Sometimes this will become wrinkled. Leave it alone. Don't take it apart, because if you do, the whole thing could fall off. This one doesn't have that worry, but you do have the worry that it is a pin going through the bone, through the skin, so the chance of infection is great. You will have an order for skin care, for pin care. It's usually done once a shift. They typically are using chlorhexidine, which is a very good killing agent. And this kills even after it's dried. It will kill on the skin surface for 14 hours. We do not encourage you to wrap wet alcohol or wet chlorhexidine wraps around it. But you're going to clean the site, remove the dressing, clean the site, and then put a sterile dressing around it. So that's skin versus skeletal. Also, you need to be aware of the difference between balanced and straight. Balanced traction involves ropes and pulleys. Okay, notice here we have balanced traction, and we have this rope, we have a pulley, and then a weight. The amount of weight is determined by the orthopedist, enough to cause this muscle mass to allow the bones to lie side by side or connecting to each other. If the patient sits up a little bit, can't sit up much because of this, but the rope would shorten and the weight would go down, traction still intact, not a problem. Here we have straight traction, and that's when the ropes go to a stable bar. If I pick this child up even a little bit to change the bed, it would cause this rope to wrinkle and he would be not in traction. So for me, I prefer balanced traction because it allows me some mobility. Always your traction, though, should go straight to the first device. Notice it's straight up to the bar. Notice it's straight up to the first pulley. You need to know the nursing care for both straight and balanced traction, for skin and skeletal traction. Brian's traction is for a young child with a fractured femur. If they have both legs in traction, even though this is only one leg broken, both legs are in traction because without it we can't get sufficient counter traction. So both legs are in traction, his buttocks are off the bed, and the head of the bed is down. So he is kind of in this slant, adding more counter traction. And that is the position he's got to stay in. If they put you or me in that position, our legs would fall off. We don't have the circulation to maintain it. So it's usually we only use it until they're about 3 years of age. And then we have more counter traction. Probably he was willing to get rid of the motorbike. Okay, now let's look at this child. This child is in balanced skeletal traction, straight skeletal traction, balanced skin, straight skin. Okay, let's look. First of all, is it balanced or straight? Are there ropes, pulleys, and weights? Nope, going right to a bar. So it's straight traction, and he's got the ACE bandages, so that means it's skin traction. So he's on 4, straight skin traction. Immediate care of sprains and strains: ice, rest, compression, and elevate. You should know that already. And another little comic. Wonder what the endorsement they have. And that finishes our program. Thank you.